Hello dear students. In this lecture we will be talking about multifetal pregnancy. Multifetal pregnancy refers to any pregnancy which has an order of more than one. That is, it can include twin pregnancy, number one twin pregnancy with two gestations, or it can be a triplet pregnancy, or it can be a quadruplet pregnancy, and so on and so forth. So we will be discussing basically twin pregnancy, followed by a bit about triplet and quadruplet pregnancy. At the very onset, I would like to tell you that multiple pregnancy or twin pregnancy can be basically of two types. One is dizygotic twin pregnancy, and the other can be monozygotic twins. So what do you mean by dizygotic and monozygotic twins? By dizygotic twins, we mean that two zygotes were formed in the very initial stage. The two zygotes formed means in the same cycle, two eggs were released, two ova were released, and were fertilized by two different sperms. So dizygotic twin was formed. So dizygotic twins are also called as fraternal twins. Fraternal twins because they have different genetic material and they are different. So they can be of the same gender or they can be of different gender. They have very different structures. So they have two different placenta, two different chorions, two different amnions. Everything will be different for them. So they are dizygotic twins. But there can be monozygotic twins also. It means one zygote was formed initially because one ovum and one sperm was there. But during the course of division, cell division, basically they divided into two parts and both of them started forming a different embryo. So two embryos were formed and two different individuals were formed. So it is very important at what stage of the development was the division occurring. So always remember at day 3 of life. At day 3 of life, it is basically the chorion which is formed. So the chorion is formed at day 3 of life. Chorion or the chorionic membrane is formed in day 3 of life and it divides. At day 8 of life, the amnion is formed. Amnion or the amniotic membrane is formed and it divides at day 8. Then comes day 14. At day 14, it is the embryonic disc which is formed. Embryonic disc is formed at day 14 of life. So basically these 3 days are very important: day 3, day 8 and day 14. So see, if the cell division, that is the division, has taken place into two embryos, if the division has taken place before day 3, so both the fetuses will form their own chorion at day 3 and then they will form their own amnion at day 8. So they will have their separate amnion and separate chorion. So it will be a dichorionic, diamniotic gestation when the division of the zygote occurs before day 3. But if the division occurs at this time, that is between day 3 and day 8, then what happens? At day 3, the zygote had formed its own chorion. So chorion was already formed at day 3. After that, the division has taken place and now they are two embryos. So at day 8, they will form their own amnion. So amnion is formed differently. So now they are having one chorion but two amnions. So it is a monochorionic diamniotic gestation when the division of the cells have taken place at between day 3 and day 8. When the division occurs at between day 8 and day 14, then what happens? Already there was one embryo, so one chorion was formed and one amnion was also formed at day 8. After that, the division has taken place and now there are two embryos. So there is monochorionic and monoamniotic gestation, MCMA twins, when the division has occurred after day 8 of gestation. But after day 14, if the division has taken place, then the embryo has already formed its embryonic disc. So certain parts of the fetus is shared between the two fetuses. So what happens is that there is conjoined twin which is formed. So conjoined twin is formed when the fetuses are dividing after day 14. After day 14, if they are dividing, then it is conjoined twin, or it is also called as Siamese twin. Siamese twin, because it was first discovered, the first conjoined twin was reported at Siam, so it is also called Siamese twin. Now, Siamese twins have certain parts of their body which is common between the two fetuses. So, depending upon that, there are various nomenclatures which are given. Number one, it can be thoracopagus. Thoracopagus. Thoracopagus means, pagus means it is joined. Thoracic means it is in the chest is joined. When the chest of both the fetuses are joined, then it is called as thoracopagus. Okay, so this is the joining of the chest. Then there can be ischiopagus. Ischiopagus means there is joining at the level of the pelvis. Pelvis of both the fetuses are joined. It can be pyopagus. When the back of both the fetuses are joined. When the back is joined, it is called pyopagus. Or it can be Craniopagus, when the joining of both the fetuses are at the level of the head. If the heads are joined, then it is Craniopagus. So difficulty is there of separating when the head is joined or the thoracic chest, that is the heart, is joined. Otherwise, pelvis, back or limbs are joined, then it is it is not that difficult to undergo surgery. So all these basically are complications of monozygotic twins, whereas dizygotic twins are generally not having much complications because they are formed from two different zygotes, and so their genetic material is different. Now, very important concept which I am going to talk at this moment is what is Helin's rule. Okay, so Helin's rule says that basically over the world, the incidence of monozygotic twins is constant. It is constant over the world. The difference is at the level of dizygotic twins. Okay, dizygotic twins, the incidence keeps on varying from region to region. Dizygotic twin, the incidence keeps on varying from region to region. Okay, the incidence of twins is highest in Nigeria. In Nigerian country, the incidence of twin is highest. It is around 1 in 20 population has twins, whereas it is lowest in Japan. Regarding the country, the incidence of India, there has been questions in NEET examination. That is why I am talking again and again. Incidence of twin pregnancy in India is 1:80. 1:80 is the incidence in India. So this varying incidence is because of varying incidence of dizygotic twin. Otherwise, monozygotic twin incidence is constant all over the world. Okay. Now, one more thing, what is Helin's rule? Helin's rule says that the mathematical frequency of multiple pregnancy is 1:80 to the power of n minus 1. 1:80 to the power of n minus 1. So it means that if it is a twin pregnancy, or order is 2, then the incidence of twin is 1:80 to the power of 2 minus 1 is equal to 1. Okay, so 1:80 to the power of 1, it means incidence is 1:80. Okay, is the incidence of twin. If somebody tells you what is the incidence of triplet pregnancy in India, so by Helin's rule, it is said that 1:80 to the power of triplet 3, n is 3 minus 1 is 2, 1:80 to the power of 2, that is the incidence of triplet pregnancy in India is 1:6400. So this is Helin's rule. Helin's rule is applicable for India. Now, during this age, why the dizygotic twins? Nowadays, dizygotic twin incidence is increasing. Why dizygotic twin incidence is increasing? This is because of the increasing incidence of IVF pregnancies. IVF pregnancies or ART pregnancies, artificially reproductive technique pregnancies. This is because when we used ovulation induction drugs, when they are used, basically your clomiphene citrate and letrozole, these induce ovulation. This means they will induce the formation of eggs in the ovaries. Okay, now because of these drugs, they are generally inducing more egg formation than the natural one. So they are leading to two eggs being released at the same time. When two eggs will be released, so sperms are excess in number, so two zygotes will be formed and dizygotic incidence will increase. So dizygotic twin incidence is increasing because of the increasing incidence of ovulation induction and IVF pregnancies worldwide. Now, some of the very important facts which I'll be telling, because exam questions also come in NEET, is the number of chorion or chorionicity is directly proportional to the number of placenta. This means if it is a monochorionic gestation, then you have one placenta, and if it is a dichorionic gestation, then two placenta is formed. However, in dizygotic twins are always dichorionic, diamniotic, because they have two zygotes, so they will always form their different chorion and different amnion. Whereas it is in the monozygotic twins that DCDA, MCDA and MCMA twin will be formed. Okay, so these are all types of monochorionic gestation. Okay, before 10 weeks of gestation, that is when the fetus is very small, then the number of chorion, okay, will be directly proportional to the number of G-sac, number of gestational sac. So if you see a very early uterus, the number of G-sacs that you find will be proportionate to the number of chorion will be formed. Okay, if it is like, if the gestational sac is 1, if there is one gestational sac and two fetal poles, then it means it will be a monochorionic gestation. Whereas if two gestational sacs are present at less than 10 weeks, then it is suggestive of dichorionic gestation, because less than 10 weeks placenta won't be formed, and later on it is the number of placenta that will be corroborating with the number of chorion that is formed. Okay, best time to look for chorionicity in the ultrasound. Chorionicity is best determined at the scan which is done between 11 to 13 plus 6 weeks, that is 11 to 14 weeks. Okay, so the gestation, that is 11 to 13 weeks, when we check for nuchal translucency, NT and nasal bone, that is for aneuploidy screening or for Down syndrome screening, the scan which we do at 11 to 13 plus 6 weeks, at that time only, if it is a twin gestation, then we try to look for the chorionicity of the fetus. Now, how do you differentiate between chorionic, that is monochorionic, and dichorionic twins? Very important, and questions also come. Monochorionic gestation versus dichorionic gestation. So, always remember, coming to placenta. If it is a placenta, then placenta will be single in monochorionic gestation, whereas it will be double placenta in dichorionic gestation. Then coming to the fetal gender. Remember, monochorionic gestations, there will be concordant gender. Means if one is male, the other will also be male. One is female, the other will also be female. But in dichorionic gestation, it depends. If it is a monozygotic twin but it has divided, then it will be concordant. Okay, concordant, because monozygotic था तो सेम जेनेटिक मटेरियल ही था, तो सेक्स भी सेम होगा. बट इफ इट इज़ अ डाइजाइगोटिक, ट्विन से डाइकोरियोनिक हुआ है, then it can be discordant also. One male and one female can also be there. So both can be there in dichorionic. Then coming to the membranes, the fetal membranes, okay, that is the amniotic membranes. Okay, so what is the thickness of the membrane in monochorionic gestation? It is less than 2 millimeter. So thickness of the intertwin membrane is also very important. This membrane thickness is more than 2 mm. Okay, how do you denote it? Suppose I am showing an example. Suppose if you do ultrasound of the uterus, okay, two fetuses are there, you focus your ultrasound in this part of the thing and you try to look for what is the thickness of this intertwin membrane. If the intertwin membrane is very thin, if it is very thin, here is one fetus and the other fetus is here, if it is very thin and it is the thickness is less than 2 mm, then it is most probably a monochorionic gestation, and it is also called as T sign. It is called T sign of the intertwin membrane. T sign because see, this is a T which is formed, an inverted T or a T which is formed. Okay, so that is why it is called T sign. Whereas if it is dichorionic, then the fetal membranes will be wide apart. It will be dividing this way. Okay, means one fetus will be here, the other fetus is here. Okay, so the intertwin membrane distance will be more than 2 mm and there will be a tissue which will be in the intertwin membrane. So because of that, this is a sign which is called the lambda sign. So see, it is like this, it is actually like this. So it is called the lambda sign. Okay, lambda sign. So lambda sign is suggestive of a dichorionic gestation, whereas T sign is suggestive of monochorionic gestation. Okay, this lambda sign is also called twin peak sign. Okay, twin peak sign, very very important, and questions come. Twin peak means there are two peaks, one is this peak, one is this peak and the other is this peak. So दो mountains की तरह दो peak हो गए, and this is also called the lambda sign. It is visible in dichorionic gestation in ultrasound. Okay, and number of GSAC, number of GSAC at less than 10 weeks, क्योंकि less than 10 weeks में intertwin membrane भी नहीं form होता है and placenta भी नहीं form होता है. So if there is single GSAC, then it is a monochorionic gestation. If it is two GSACs, then it is suggestive of dichorionic gestation. So this is very important and you should never forget. Okay, so this is what is very important at this part. Now one more thing I would like to tell you, one more question comes. What is the incidence of monozygotic and dizygotic twins? Remember, most of the twins nowadays are dizygotic twins because I have told कि IVF pregnancies बढ़ रहा है worldwide, and so dizygotic twin incidence is increasing. So 75% of twin pregnancies are dizygotic twins, whereas your 25% are monozygotic twins. All dizygotic twins are DCDA, dichorionic diamniotic, whereas monozygotic twins I have told can be dichorionic diamniotic, monochorionic diamniotic and monochorionic monoamniotic depending upon कौन से type, कौन से day of the life में division हो रहा है. So basically overall the most common incidence is DCDA twin, dichorionic diamniotic gestation, followed by monochorionic diamniotic, and MCMA is the least common type of chorionicity which is found. Most common is dichorionic diamniotic. Okay, now next question which comes, which is always asked to you, is what are the complications of twin pregnancy? What are the complications of twin pregnancy? Okay, so complications of twin pregnancy can be divided. Always remember, whenever in exam you get question on complications, then try to divide into maternal complications and fetal complications. So you have maternal, you have fetal complications. Okay, so maternal and fetal complications can be broadly again classified into antepartum and postnatal complications. Antepartum and postnatal complications. So complications, sorry for the technical glitch, complications we have first divided into maternal and fetal complications. So maternal complications can be again divided into antepartum and intrapartum complications. Antepartum means when the baby is in the womb, what are the complications that a twin pregnancy can happen. Okay, so starting from the first trimester, patient will have hyperemesis gravidarum. Hyperemesis, why it will happen? This is because the beta HCG value is double of normal pregnancy. एक प्रेगनेंसी से ज़्यादा अब 2 प्रेगनेंसी है तो बीटा HCG वैल्यूज डबल है. So that is why beta HCG is high. So patient will have more of vomiting, nausea and vomiting of pregnancy. More than that, patient will have polyhydramnios. Polyhydramnios hoga, then patient will have distension, patient will have abdominal pain. If there is polyhydramnios, then patient will also have PPROM, that is preterm pre-labor rupture of membranes. And since the hormones and everything are raised, patient will have preeclampsia, blood pressure will increase, and patient will also have maternal anemia because the baby's requirement will be high. And if patient has PPROM and membranes are ruptured, then there will be sudden decompression and placenta will separate from the upper cavity, and so patient will have abruptio placentae. There is chances of abruptio placentae because the membranes have ruptured and there is sudden gush of fluid which has come out, so placenta is separated from above. Also at the same time, for 2 babies the placenta will be large, and so the placenta will come and cover the lower part of the lower uterine segment also, and so patient will have placenta previa also. So these are the antepartum complications. Intrapartum complications are because there are 2 babies in the uterus at this time. There can be dysfunctional labor. By dysfunctional labor I mean to say that patient can have a very prolonged labor because 2 babies are there, and so there can be delay in the progress of labor. There can be malpresentations means there can be chances of breech presentation, there can be chances of transverse lie, and at the same time after delivery there is increased chances of patient landing up into cesarean section, and then operative deliveries are high. Thereby after the delivery patient can have postpartum hemorrhage because large uterus will not be able to contract properly, and there can also be chances of retained placenta after delivery. So these are the complications which can be there in maternal. Coming to fetal complications can be, it can be divided into antepartum and intrapartum or postpartum complications. Intrapartum, okay. So during the pregnancy what can happen to the baby? There can be prematurity because babies will be small, because 2 babies are sharing the same uterus, so babies can be small. There can be FGR, fetal growth restriction can be there. Then there can be other complications which are specific to monochorionic gestation. Now this is important and it comes in examination. So what are the complications specific to monochorionic gestation? So monochorionic, be it MCDA twin or be it MCMA twin, that is monochorionic diamniotic or monochorionic monoamniotic. Monochorionic twins have certain complications which are specific to them. What are these? Number 1, twin transfusion syndrome, TTTS, twin transfusion syndrome can be there. I will explain each of them separately, don't worry. Then you have TAPS, twin anemia polycythemia sequence. Number 3, it can be TRAP, twin reverse arterial perfusion. Number 4, there can be selective FGR, that is selective FGR, SFGR. Then there can be vanishing twin, very important because questions come from all these. Vanishing twins can be there. Okay, and then there can be acardiac twin. Trap is also called acardiac twin. Okay, acardiac twins, these all can be there. Now what are the complications specific to monochorionic monoamniotic? Means only MCMA twin will have this complication is cord entanglement. Cord entanglement. Okay, means, see, now understand it. MCMA twin, both the fetuses are in the same amniotic fluid, amniotic cavity, and same chorionic cavity. So they are same. So they will be moving here and there, and then there can be chances of entanglement of cord. एक का cord दूसरे के cord के अंदर फंस गया, तो उसमें क्या होगा, जब फर्स्ट डिलीवरी होगा तो कॉर्ड खींच के आ जाएगा एंड नेक्स्ट बच्चे का कॉर्ड टेयर हो जाएगा एंड नेक्स्ट ट्विन का डेथ हो जाएगा पेट में. सो दिस इज वेरी कॉम्प्लिकेटेड फॉर कॉर्ड एंटेंगलमेंट. दैट इज वाई MCMA twin always should go for elective cesarean section. There is no chance of normal vaginal delivery in MCMA twins because they are in the same amniotic cavity and एक ट्विन के डिलीवरी के बाद कॉर्ड खींच सकता है and there can be death of the second twin. So MCMA always go for elective cesarean, whereas MCDA and DCDA can be given chances of normal labor provided that the T1 is cephalic. T1 is cephalic. What do you mean by T1? Now remember the twin which is below, that is, suppose this is one twin, okay, and this is the second twin. Okay, so this is the second twin. So the first twin is the one whose presenting part is felt by the PV examination. पीवी एग्जामिनेशन में जिसका प्रेजेंटिंग पार्ट फील होता है, मतलब जो वाला फीटस नीचे रहता है, दैट इज ऑलवेज टर्म्ड एज T1 फर्स्ट ट्विन, and then the other will be termed as T2. Okay, T2. So if the T1 is cephalic means first बच्चे का हेड आ रहा है नीचे, then only we will give trial of normal vaginal delivery. Otherwise, in all other conditions, you have to go for cesarean section. It is irrespective how the T2 is presenting. T2 चाहे ब्रीच हो, चाहे केफेलिक हो, चाहे ट्रांसवर्स हो, उससे कोई मतलब नहीं है. जस्ट वी विल सी कि T1 का क्या प्रेजेंटेशन है. इफ T1 is cephalic, go for trial of labor because the head is a very good dilator for the cervix. If the T1 is not cephalic, then always go for cesarean section. One dangerous complication can be interlocking twins. Now what do you mean by interlocking twins? Interlocking twins occur when T1 is breech, first वाला बच्चा breech है, and second वाला बच्चा is cephalic. So I told first breech होगा तो हमेशा cesarean करना है. Why this is so? क्योंकि अगर first बच्चे को breech delivery का trial देते हैं, जब when it comes below, then what happens? Before the head of the T1 comes, the head of the T2 will come. तो क्या हो जाएगा? फर्स्ट ट्विन का बॉडी डिलीवर होगा एंड सेकेंड ट्विन का हेड डिलीवर हो जाएगा एंड वो फंस जाएगा. उसके बाद क्या होगा? यू हैव टू कट बोथ द फीटसेस. एक का बॉडी निकलेगा, एक का हेड निकल जाएगा नीचे से, दूसरे का हेड एंड दूसरे का बॉडी आपको ऊपर सिजेरियन करके निकालना पड़ेगा. सो बोथ द फीटसेस विल डाई. सो देयर विल बी इंटरलॉकिंग ऑफ द ट्विन्स विल ऑकर. So this is why when T1 is breech, you never give trial of labor. Okay. Now coming to the specific complications, we will talk one by one. Number one is TTTS. What do you mean by TTTS? Okay. Twin transfusion syndrome. Twin transfusion syndrome is a syndrome which is always seen in monochorionic twins. Very important because questions come from TTTS. Okay, in monochorionic twins में twin transfusion syndrome देखा गया. What is the pathogenesis? Why एक twin से दूसरे twin में transfusion हो रहा है? This is because there is AV malconnection. What do you mean by that? It means one of the fetuses, ये एक fetus है ओके, ये एक फीटस है, ये दूसरा फीटस है, बच्चा अंदर, ठीक है। सो वन फीटस का जो आर्टरी है दैट इज अम्बिलिकल आर्टरी विल बी कम्युनिकेटिंग विद द अदर फीटसेस अम्बिलिकल वेन. सो AV मैल कनेक्शन, अम्बिलिकल आर्टरी एंड अम्बिलिकल वेन के बीच देर विल बी मैल कनेक्शन बिटवीन द टू. ओके, so when there is mal connection between the two fetuses, then it is called twin transfusion syndrome. So what actually is happening is one umbilical vein is having connection with the other umbilical artery. So this baby's umbilical artery is communicating with umbilical vein of the other fetus. So what happens if the umbilical artery of this baby is communicating with umbilical vein of this fetus? So every time इसका आर्टरी है तो आर्टरी में ब्लड प्रेशर ज़्यादा होता है, वेन में ब्लड प्रेशर कम होता है बिकॉज इट गोज टुवर्ड्स द हार्ट. So what happens every time blood will flow from this fetus to the other fetus. So from fetus A जिसका umbilical artery से connection है उसका blood हमेशा umbilical vein वाले fetus में जाता रहेगा. तो what will happen is this fetus will drain its most of the blood to the other fetus. Okay, so this fetus will have lack of blood, so there will be less of blood volume in this fetus. ये फीटस का ब्लड वॉल्यूम कम होता जाएगा, इस फीटस का ब्लड वॉल्यूम विल कीप ऑन इंक्रीजिंग. सो व्हेन द ब्लड वॉल्यूम ऑफ दिस फीटस कीप्स ऑन इंक्रीजिंग देयर विल बी हार्ट फेलियर इन दिस फीटस विल हैव हार्ट फेलियर. सो व्हाट हैपेंस इज this baby will have low blood volume will lead to less of urine production, because अगर blood का मात्रा कम रहेगा बॉडी में so urine production भी कम होगा, so less of urine production in this baby. When the urine production will be less, so basically it will have oliguria हो जाएगा, and because of oliguria this baby का जो amniotic fluid है that will decrease, and then this baby will have oligohydramnios. Okay, so इसके अंदर पानी कम हो जाएगा, whereas the other fetus will be plethoric. Plethora means there will be congestion of blood in this fetus, and so it will be a pressure upon the kidneys, so more and more of polyuria will occur, urine will be produced more, and then it will lead to polyhydramnios. Okay, so basically it is a poly sequence, oligohydramnios polyhydramnios sequence, which is also called as poly sequence. ओके, मीन्स एक बच्चे के अराउंड ओलिगोहाइड्रामनियोस रहेगा, दूसरे बच्चे के अराउंड पॉलीहाइड्रामनियोस रहेगा, poly sequence. So this is actually called twin transfusion syndrome, or it is also called TOPS, that is twin oligohydramnios polyhydramnios sequence. It is more common in female fetuses, में more common होता है, ठीक है, and it is a cause of polyhydramnios. Okay, so what happens actually, one of the fetus, if you do an ultrasound, one of the fetus will become very small, it will be IUGR, and the other fetus will be very big and उसके आसपास ज़्यादा पानी रहेगा. Okay, so it will have a lot of polyhydramnios, the other will have oligohydramnios. So for diagnosing oligohydramnios, always remember the diagnostic criteria is amniotic fluid index is less than 5 centimeter, और single deepest pocket, एक pocket का अगर लिया तो ये less than 2 centimeter होगा, then it is called oligohydramnios. Whereas for polyhydramnios, amniotic fluid index, which is taken by measuring 4 quadrants, that should be more than 25 centimeters, or single deepest pocket of more than 8 centimeters is diagnostic of polyhydramnios. So how do you stage this twin transfusion syndrome? It is staged by a staging called Quintero staging. Quintero staging, Quintero, Quintero staging. Very important exam questions come. So how do this Quintero staging is done? Quintero staging has 5 stages. In first stage what happens, there is ओली पॉली sequence of course. ओली पॉली sequence मतलब एक ट्विन में ओलिगोहाइड्रेमनियस, अदर ट्विन में पॉलीहाइड्रेमनियस होगा, बट fetal bladder is visible in the smaller twin. Bladder is visible in the smaller twin. So it means कि छोटे ट्विन तो वैसे ही उसके अंदर पानी कम है, तो पानी कम होगा तो वो यूरिन कम प्रोड्यूस करेगा, यूरिन कम प्रोड्यूस करेगा तो उसका यूरिनरी ब्लैडर एम्प्टी हो जाएगा, लेकिन अभी भी थोड़ा बहुत पानी वो प्रोड्यूस कर रहा है, इट इज़ प्रोड्यूसिंग अ लिटिल बिट ऑफ यूरिन, सो यूरिनरी ब्लैडर इज स्टिल विजिबल, सो इट इज स्टेज 1, मतलब इट इज़ नॉट सो मच ऑफ बैड प्रोग्नोसिस. ओके, in the donor twin bladder is visible. In second stage what happens, there is ओली पॉली sequence and the donor twin means जो छोटा twin है will have no bladder visible. Bladder is now empty, urinary bladder is empty. Okay, so it is a poor prognosis कि अब यूरिन नहीं प्रोड्यूस हो रहा है तो ओलिगोहाइड्रेमनियस का सीक्वेंस और बढ़ जाएगा. Coming to stage 3. Stage 3 will be when there will be abnormal Doppler findings. Abnormal Doppler findings. Now what happens? The fetus is so affected that the blood vessels will not be having proper blood. Blood is not there to be not in good amount, so that Doppler is not visible. And the second twin, the recipient twin, will have so much of plethora, so much of blood that movement of blood will be very difficult. So abnormal Doppler findings are found in stage 3. Stage 4, there will be ascites and hydrops. Ascites and hydrops in the recipient twin. Hydrops in recipient twin means the recipient twin has become so much plethoric that ascites has already developed, so hydropic fetus. So this is a cause of TTTS, is a cause of non-immune hydrops, whereas immune hydrops, that is immunological hydrops, was seen in RH negative pregnancy or RH isoimmunized pregnancy या alloimmunized pregnancy में there was immune hydrops. But there is non-immune hydrops also which is found, means without RH negative antigen also baby can develop hydrops. As example in torch infection में होता है, या फिर हमारे twin pregnancy में TTTS में भी हो सकता है. And the fifth stage is when there is fetal demise, when the fetus is already dead. So the first fetus to die will be your recipient twin, because it will die of heart failure. Then the donor twin will die. Donor twin has a bit better prognosis than the recipient twin. So what is the treatment of TTTS? What is the treatment of twin transfusion syndrome? So the treatment of twin transfusion syndrome is selective. It can be selective fetal reduction. Selective fetal reduction can be done. So if it is very high stage like stage 4 or stage 5, then what happen, we can selectively kill one of the fetuses. So when we kill one of the fetuses, so generally we see कौन से fetus का Doppler ज़्यादा abnormal है. Basically the recipient twin will be more abnormal, so you can kill one of the fetuses so that this anastomotic channel gets stopped. Okay, selective fetal reduction can be done. Selective fetal reduction can be done with radio frequency ablation. Radio frequency ablation can be done. Okay, radio frequency ablation means radio frequency waves are given and one of the fetus is made to die. Otherwise you can have KCl injection, potassium chloride injection into the heart of the poor prognosis fetus, so that dies and the other twin is salvaged. Apart from that, the third criteria which is the best is fetoscopic laser ablation. Fetoscopic laser ablation. In fetoscopic laser ablation, what we do is we utilize laser to damage the interconnecting blood vessel between the two fetuses. So the AV malformation or the connection is being damaged with the help of a fetoscopic laser. And once you have damaged this interconnecting the AV connection gets disrupted, and so both the fetuses do well. So fetoscopic laser ablation of the anastomosis is the best treatment which is available, because both the fetuses can be salvaged this way. Now second, coming to TAPS, twin anemia polycythemia sequence. So what we actually do in twin anemia polycythemia sequence, this is also an AV connection. Whereby artery and venous connections have occurred, but then this is a very small connection. So when it is a small connection, थोड़ा सा ही blood जाता है एक साइड से दूसरे साइड में, तो ओलिगोहाइड्रेमनियोस पॉलीहाइड्रेमनियोस नहीं हो पाता है, बट जो ट्विन से थोड़ा बहुत ब्लड दूसरी तरफ जाता है वो एनीमिया हो जाता है, इट बिकम्स एनीमिया, एंड द अदर ट्विन विल हैव पॉलीसाइथीमिया हो जाएगा. सो वन ऑफ द ट्विन विल हैव एनीमिया, वन ऑफ द ट्विन विल हैव पॉलीसाइथीमिया. तो दिस इज कॉल्ड ट्विन एनीमिया पॉलीसाइथीमिया सीक्वेंस. Treatment is again the same. Fetoscopic laser ablation can be done to destroy the anastomotic channel. The third one is twin reverse arterial perfusion or acardiac twin. In this what happens, the connection is made between artery and artery of both the fetuses. Okay, so अभी तक artery and vein के बीच connection हो रहा था, अभी artery के बीच हो रहा है. So both will be pushing the blood from one fetus to another. But in this what happens, there will be acardiac twin. Acardiac twin का मतलब है एक ट्विन का हार्ट फेल हो जाएगा and there will be no heart will be destroyed. So it means वो पुश नहीं कर पाएगा, then blood from one fetus will go to the other fetus. So there is reverse arterial perfusion, मतलब आर्टरी से ब्लड पुश बैक होना चाहिए था लेकिन वो बैक फ्लो हो रहा है. सो व्हाट हैपन्स, एक ट्विन का ब्लड ट्रांसफ्यूज हो रहा है दो ट्विन्स में. So this will be a recipient twin, this will be a donor twin. So what happens, the artery will bring the blood and it will come to the lower extremity of the body. So the lower extremity of the body will be nicely formed, whereas upper extremity, head and all, will be very much deformed. So these babies will have lower extremity properly made, upper extremity अच्छे से नहीं रहेगा, whereas the other twin will be completely okay. So treatment will be radio frequency ablation of this twin. You have to kill because this twin has no heart and it will not survive. So these are all the complications of twin pregnancy you should remember. Now apart from this, there are some other questions which are asked. What are the indications of cesarean section in twin pregnancy? So always remember, twins with malpresentation, that is T1. If the T1 is not cephalic, then you do cesarean section. Apart from that, if there are conjoined twins, then you have to do cesarean section because conjoined twins will not come out vaginally. Then monochorionic, monoamniotic twins, you have to go for cesarean section. Elective cesarean section is done at 32 weeks for MCMA twins, whereas DCDA twins, vaginal delivery can be tried at up to 38 weeks period of gestation, and this MCDA, that is monochorionic diamniotic twins, trial of labor can be tried at 36 weeks to 37 weeks period of gestation. Okay, MCMA twin also you have to do. Then you can have discordant twins. What do you mean by discordant twins? Discordant twins means if the difference between the fetal weight is more than 25%, then it is called discordant twin. Now the denominator is always the weight of the larger twin. मतलब 25% of the larger twin का weight will be the difference between the two weights, then it's called discordant twin. Discordant twin में एक twin तो आ जाएगा, दूसरा twin तो नहीं आ पाएगा, इसलिए we go for cesarean section. Or if the weight of one of the twins is less than 1.5 kg, then also you have to go for cesarean section. Okay, these are some of the things. Or if there is some footling breach or something like that, then also you go for cesarean section. Okay. So always remember, in exam it is asked what are the complications of twin pregnancy, then how do you differentiate, how do you say that it is a discordant twin when the weight difference is more than 25% of the larger twin, or if the weight is not taken into account, then few other criteria can be there. Number one, if the BPD, that is biparietal diameter, is difference is more than 6 mm, then also we say ki it is a discordant twin, or the head circumference difference is more than 5%, then also say, or abdominal circumference difference is more than 20 mm, then you say it is the discordant twin. Other than that, it is a concordant twin, and concordant twins you can go for vaginal delivery. Always remember, after the twin, if the first twin is cephalic and normal delivery ho gaya hai, and second twin is transverse, in this case we always go for internal podalic version. IPV is done. IPV करके हाथ अंदर घुसा के उसको ब्रीच करके second twin is delivered. This is the only indication for internal podalic version. So this is all about in twin pregnancy. What is important is Helen's rule. Always remember 1:80 to the power of n minus 1. What are the complications of twin pregnancy? How do you deliver twin pregnancy? What are the indications of cesarean section in twin pregnancy? And what are the complications specific to monochorionic twins? How chorionicity can be determined? What is the best gestational age? It is 11 to 13 plus 6 weeks or 11 to 14 weeks, whatever is given in your option will be your answer. And twin transfusion syndrome, Quintero staging, and the management is something which is asked. So thank you for listening to the class, and I hope you have understood the